Hi everyone, this is Destiny from Confessions of a Former Healthcare Worker, and today we're going to talk about what it's like to work in a hospital. I worked in a hospital years ago. I was what they called a PCA, Patient Care Assistant, but I will always refer to it as a nurse's aide because you basically did that kind of work and you reported to the nurses who then reported to the doctors. When you're a PCA, doctors won't listen to you. They kind of ignore you. You don't exist in a way. Um, but that's fine because, you're working closely with the nurses whose patients you're taking care of. So when I first started, I worked in the ICU, and it was a bit of a challenge. My first day there was after orientation. We witnessed an old man pass away. The old man was in a coma, and all of a sudden he woke up. His family was there. They had been called in because they had been told that he wasn't going to live much longer. But he woke up, he knew who they were, he asked for a drink, and then all of a sudden he laid back, he closed his eyes, and he began to pass away. We watched him flatline. That was the first time in my life I ever saw anyone flatline. But I also knew the signs that he was going to pass away because my late grandfather, my grandpa Rachel, had the same thing happen where he was almost in kind of a coma in a way. He had like pneumonia and he had a massive stroke. He woke up suddenly. The whole family was there, I remember. And I remember him saying, "I'm going to go home." But his version of home was not our actual home. Because later that night, we got the call that he'd passed away. So I recognized the signs, and it was still heart wrenching watching his family, break down. But I had to deal with that a lot. The ICU usually has about 12, 14 beds. Basically, they're glassed. They're like, there's a lot of glass, so the nurses sit outside of the room and they look through the glass to check on the patient. I did some one-on-one work there, which was basically when you're one-on-one, you have to chart on that patient. You're with that patient for 12 hours. You have to chart every 15 minutes on this patient. What are they doing? Are they sitting up in bed? Are they laying down? Are they sleeping? Are they fighting with a family member? Are they fighting with the nurse? Are they, acting up? You also have to, of course, assist them to the restroom, and you have to document that. You have to document everything, especially the meals, and you had to do it in a certain way. It's basically 25%, 50%, 75%, or 100% that has been eaten. And then you had like a chart to look at to be able to determine how much they drank. And then you, of course, had to record, bowel movements every time, they did the others. You had to record that as well. I remember visiting a patient in there who was dying of cancer. And I won't exactly say visit. I mean, I did talk with him when I had a slow time because he was very lonely. But I remember giving him his food and helping him to the restroom, and he was really, really nice. And I remember it was very sad. His mother was constantly by his side. But that's what you have to deal with in the ICU because there's a lot of patients who are critical, some who are hooked up to ventilators, some who are dying, and it is challenging. But I mainly worked in the ICU as one-on-one. And since I was in a float pool, those in the float pool had to get pulled into those one-on-one shifts. So I remember also doing charting on a guy who was really nice. He had kids and everything, but he had family troubles, so he tried to commit suicide as well. So, and these people, you normally didn't talk with. I mean, there were times when I tried, but they were just didn't want to deal with anything. So, my job was to just keep charting on them. The night shifts were a bit easier because they were asleep. Daytime was usually chaos. Because there were a lot of patients where you had to do total, bed changes. Or, ones who ripped out their IVs, so you had to kind of patch them up until the nurse could come back and, reinsert that IV. So I had to learn how to be around blood. So, if somebody's bleeding, it's not bothering me because I'm used to it. One of the floors I dreaded the most was the second floor, the progressive care units. I didn't like being pulled because when you get to the floors, and you had this in ICU as well, were the isolation rooms. The isolation rooms were for those who were either had a certain form of cancer where, you needed to gown up and put a mask on or take care of that person, or they had, a lot of times they had C. diff or MRSA. So you had to don your PPE, which consisted of a special gown. It was like a paper gown. You had to put on your gloves, your mask, and sometimes, glasses, which I normally wear glasses, so I didn't have to do that part. But there was a process that you had to do in the isolation rooms. And, many times you always had to do a bed change on these patients, and it was a challenge, especially with the smell, and especially patients who were a bit difficult. But you had to, you had to get them cleaned up. And some of the patients you had to put a pull-up on, or, almost like a bed pad, and kind of pull it up. It depends how bad the person was. And then once you removed the PPE, you then had to wash your hands really well. And of course, you also had to, if you had to bring in a Dynamap, or even the pen that you used to write things down, like their blood pressure, their temperature, their aspirations, you had to wipe everything down with special wipes. There were two special wipes. There was the purple wipes and the orange wipes. The purple wipes disinfected things very quickly. The orange one took a few minutes to. It was like a bleach type wipe that you needed to use to wipe down so that you didn't end up with C. diff. And it was the same thing with MRSA. Because when you work in those type of environments, you run the risk of, if you don't wear your PPE and you don't wash your hands or your sanitizer, you run the risk of getting that. Thankfully, I didn't, because I always wear my PPE. The hardest thing was having to do one-on-one in these isolation rooms. That was a bit of a challenge because you had to wear all that PPE, and at the same time you had to document what was going on with the patient, were they being combative, and so I often hated being in those rooms because it was just it was very hard. I mean, my phone, I would have to even wipe down my phone if I had my phone with me. But like any other type of combative patient, you had to document every 15 minutes. Our breaks, sometimes you didn't get a break, except maybe a lunch break. If you were lucky, you got a lunch break, half an hour. And like I said, 12-hour shifts. Also on the floors, they would give you a certain amount of patience. The normal amount of patients was 7 to 10, which was fine to take care of. I know that doesn't sound like a lot of patients to care for during a 12-hour shift, but believe you me, it is when the bells start ringing, the call bells. It's a lot. If we were short-staffed, the most patients I ever had to take care of was about anywhere from 15 to 17 patients. And that was a nightmare. But there's just something I didn't like about the progressive care unit. I just, it was kind of a rough unit for me to work in, but I still did my very best. And how the floors work is you would clock in, they had a machine, and you would go back, and the other PCA would give you the report on their patients. And the report was basically why the patient was in there, whether they were 2 assist, a 1 assist, or they were able to get around on their own. You also had to know ones that needed compression socks, ones that needed to be, if they were bedbound, you had to reposition them every 2 hours. Every 1 or 2 hours, if I am remembering correctly. And I positioned them, you had to document it. Whether you put them on their right side and you put like a pillow behind them, you had to document that they were laying on their right side, and then you'd have to move them to the other side. And then sometimes you'd let them lay, normally flat. And you had to make sure that you did that, because if not, they would get bed sores and you would get in trouble. I remember, it was very intimidating when I first started, because you basically had a PCA that you worked with. I ran into a lot that were going to nursing school, so they were more concerned with studying for nursing school than they were taking care of their patients. So I would often get suckered into taking care of their patients too, which was a challenge. And we also would have to deal with bed alarms. If you heard a bed alarm going off, you had to jump and you had to run to find where that bed alarm was going off at and stop that patient from getting out of bed. Because if somebody fell, you then had to call RRT, Rapid Response Team. They would all come and basically assess the patient, get them on a backboard, take them to the ER to make sure that they were okay. That was what would happen with falls. And unfortunately, I did have a few patients that fell. And sometimes it was because I didn't always get the assistance that I needed. No, sometimes I would ask somebody and they're like, I don't have time. So I would have to take care of these 2 assist patients. And sometimes if they started to fall, I had to try to keep them from falling, or I had to help them to the ground without them falling on top of me, which is basically what happened, that I got injured. Was trying to save a patient who was trying to get out of bed. So the second floor, it was a challenge. Of course, so was the third floor, the med surg floor. It was just as challenging. You had the same thing. You had, on one side of the wing, you had the isolation patients. Then you had the rest of the patients. And you had to do vitals on them 3 times a day, 3 times a night. These patients didn't always like that. Some of them could get nasty. They didn't like you coming in bothering them when they were trying to sleep, or, if they were sick. They didn't like having somebody come in and constantly doing vitals, but we had to do it. We had to do it for the doctors, so the doctors knew, whether this patient had a high blood pressure, whether this patient's respirations were very shallow, or if they had a high temp. We had to chart everything. Charting was very, very important. If you didn't chart it, that meant it didn't happen, and you could get in trouble for that. But basically, what you charted, the nurses would look at, and then the doctors would look at. So, yeah, I dealt with a few RRTs, and then, of course, you have to document. They have somebody that comes up and documents what happened, how the person fell, and sometimes if that person is normally trying to get out of bed while they're there and starts to get a little combative, then that's when you have to do the one-on-one. I sometimes I had patients that were, they fell asleep, they were fine. So, it wasn't as challenging when I did one-on-one, but then I had patients who could be very abusive. I was slapped, I was hit, I was punched in the stomach. I almost had my one hand broke by a patient, and I was almost strangled. And the thing about it is that, and I say this because this has become a problem with our country in the healthcare industry. And that is, especially in the ERs, combative patients can get really super violent. And a lot of people get hurt. And I remember reading about a PCA who got injured doing his job and couldn't go back to work for a while. I read another report where a security guard was killed. And that is the risk that you must take when you do this job. You have to realize it. And they didn't tell me that when I signed up for that job. When I did orientation, I had no idea. I remember the first patient on the floors that I had to take care of was an elderly man who was he had a daughter that would be there during the day trying to help, but he had a UTI, so he was just really nasty. I remember I had a urinal thrown at me. I had a duck because he threw it at my head. It wasn't full or anything, it was an empty urinal. But we then had to take everything away, including the phone. Anytime they go out like that, you had to remove things away from them, including their tray table, because you couldn't let them find another weapon. If they got too bad, then the doctor would come in and they would have to sedate the patient. Usually the nurse would come in and she would say, okay, I'm going to flush your IV. And then they would give them something to sedate them and either calm them down or put them to sleep. And I remember being terrified because I had to work with this man during the nights. Thankfully, he slept most of the night. But I was able to get a really nice PCA who was working the floor, and she came and helped me do a total bed change because I was just terrified. I was terrified of this old man who had tried to throw something at my head earlier around supper time. It was intimidating, and it was scary. I also had a situation where I was in the room with a patient, a young boy who, you know, he had mental health issues. He was wanting to be committed because he knew he had these issues. And I had to do one on one. I remember trying to talk to him, trying to put it on a channel where they maybe play music to try to get his mind off of things. But no matter how hard I tried, you know, it didn't really work. And he started to get a little violent. He got to the door before I did and shut the door. And I remember trying to back up, trying to find something to defend myself with, even though you're told you're not allowed to defend yourself. You have to take, they slap you, they hit you, you have to take it. You have no choice. They say it's part of your job. I think it's a dangerous part of the job. I think that something needs to be done about that part of the job because I have serious PTSD from that part of the job. But the young boy showed us in there, and I remember, you know, getting to the call button and screaming for, code gray, which is basically when a mental health patient becomes combative, then a whole team comes in to try and talk him down. So thankfully, I was rescued, should I say, and brought out of the room while more trained professionals went in there to talk with him. And they were able to calm him down and get him back to the ICU so that he could be taken to the behavioral health unit, to a psych ward. That was very scary. I didn't know what to expect. One minute he was nice, the next minute he could just start getting in this rage. And even though you're told that when you document, you have to have your back against, facing the doorway. So if they become combative, you could just get out of there faster. But this kid, he said, I have to use the restroom. Could you please help me? And that's how he got me. I was escorting him to the bathroom. Really, he was able to go himself, but had been letting on that he couldn't. And yeah, he tried to trap me in the room with him. And I remember being scared. And I also remember having to do one-on-one with 2 patients in the same room. One was trying to rip off his EKG leads, which they tape on, and they wire you up. And the other patient kept trying to get out of bed. So I had 2 patients that I was taking care of because we were short-staffed. And I remember feeling overwhelmed, upset, and so angry. And to me, it was very dangerous. I know we were short-staffed, but it was very dangerous being one-on-one with 2 combative patients. So, yeah, that's something else that you have to expect when you become a PCA and you're working the floors, is that you will have to do one-on-one with patients who are combative. And you have to just kind of, if they start trying to hit you, just try to get out of the way in time. But that ends it for today. I'm preparing for something big. But I will be back again to discuss more about working on the floors and combative patients and what else to expect, especially when working in rehab or the ER. So tune in next time, and I hope to see you again. Have a good day. Bye.